basically we are going to learn about the definition, description, categories of different health systems in the world, comparison of American, British, French, Australian, Canadian and Eastern countries, look at the advantages and disadvantages as a health system and then measuring the health system performance. So, to do that, you all agree that healthcare is a right. Every human being has a right to get what he wants, to lead a healthy life. So, basically, in all the countries, healthcare is so we are trying to look at systems, how these addresses this is encapsulated in the Universal Declaration of Human Rights. They talk about it in Article 25 of the General Assembly of the United Nations, which was adopted and proclaimed these principles in 1948. Article 25 talks about everyone has the right to a standard of living adequate for health and well-being of himself and of his family, including food, clothing, housing and medical care, and necessary social services, and the right to security in the event of unemployment, sickness, disability, widowhood, old age, or other lack of livelihood circumstances beyond his right. So, it is embodied in the Universal Declaration of Human Rights that health. So, health system should be geared to address these parameters that was adopted by the United Nations as a basic human right. So, everyone has the right to a standard of living adequate for health and well-being. Who will pay for it? Who will pay for it? Okay, health is a basic human right. Everybody has a right to access to it, but who is going to pay for it? Individuals? Yes. One way is the tax revenues will pay. Right. Okay. Then these are collected as taxes, and then the governments use that to provide you the services necessary. So, one way is the tax revenue takes care of that. What is the other method of payment? Yeah, insurance. Yes, insurance. Some insurance companies will take over that function, and if something happens, they bear the cost of this thing. And then the third. Yes, third one is the out of pocket, so the individual paying. So, healthcare can be the cost of will be taken care of either on these three methods, either by tax revenue, insurance. So, there are different health systems models which have combinations of these. Right? What is our system here? Basically, mostly it's the tax revenue, right? Tax revenue, and the government collects taxes from people. Even if you buy a tube of toothpaste, you are paying taxes. So, even the poorest person who buys that, and the money collects that money, that taxes, and then you can access healthcare without any charge. That's a beautiful system. That's why people have envied this system in Sri Lanka, and we are providing free healthcare to the people. It's not really free. People are paying by way of taxes, and ours is a tax-based system of this thing, and very little insurance and out-of-pocket payment are also there. Right. Basically, that is that. Right. So, the governments does not make money out of this. Their responsibility, because it's a basic human right. What they do is if they want, they print the money and provide the services. And then there are different models, different healthcare models that are there currently. Each nation's healthcare system is a reflection of its. If you look at analyzed the health systems of countries, and it reflects some things have evolved over time. So, from the history you can see how health systems have developed. Then politics, right, economy and the national values. These are reflected in the health systems about the politics of that country, about the economy of that country and the national values. They are all vary to some degree, right. So, different when you analyze health systems, you will see that this change differs from this thing. Some countries have historically developed health systems, politically, economically and national values system. However, they all share common principles, right. What are those principles? There are 4 basic healthcare models around. If you look at all the systems, healthcare models, you can put into one of these 4 categories basically. So, they talk about 4 basic healthcare models around the world. One is they call the Bismarck model. What is this Bismarck model? Anybody knows what this Bismarck model is? Germany, Japan, France, Belgium, Switzerland and Latin America, these countries have this model in common. It's named for Prussian Chancellor Otto von Bismarck. It comes from his who was the inventor of this welfare state model, right? Bismarck. Otto Bismarck, he is the one who invented the welfare state model, and from him that name has been given. What are the characteristics of this model? Providers and payers are private. Right? Both provided. The health, when you take a health system, there are people who provide it, then there are people who provide funding, then there are people, whether it is public or private. Right? So, in the Bismarck model, providers and payers are private. So, it's all government doesn't get involved in that. They are all private, the people who pay and the people who provide. Privately provided, privately financed system. Private insurance plans financed jointly by the employees through payroll deduction. So, they have insurance system. It has to be paid. The people cannot. They have an insurance scheme, but it comes through the employment. They have seen they charge and have their private insurance plans for their employees, and then if they get sick, they are provided through that. Then plans cover everyone and do not make a profit. So, in this Bismarck model, it covers everybody, universal coverage, and do not make. So, they are mainly giving coverage to the people. They are not going motivation in not making a profit. In Latin America and Bolivia, those countries, they have this model, pro health, pro salud and all that, where it's privately run, privately provided. And then the second model is called the Beveridge model. It was named after William Beveridge. He is the one who inspired the Britain's national health system, NHS. Great Britain, Cuba and the US Department of Veteran Affairs have this model. What are the characteristics of the Beveridge model? Their healthcare is provided and financed by the government. Right. Earlier one, it was the privately provided. Now here in the Beveridge model, the provision, the healthcare provision and financing is by the government through tax payments. There are no medical bills in this model. Medical treatment is a public service, right? And providers can be government employees, right? So the government and they provide the services. Low cost between the government controls costs and the sole payer. So that because of that, because government this thing, they maintain low cost in this model. This is probably what Americans have in mind when they think of socialized medicine, right? They were trying to go into that, and right, this is probably what the Americans have in mind, and when they think of socialized medicine. So that is the second model, beverage model, where there is publicly provided, publicly financed systems of health care. Then the third model is the national health insurance model. I think Canada have that national, you have a national, he will be talking about that in more detail. Taiwan, South Korea, they have this model. Here, the providers are private. Again, the providers are private, like in the earlier first model. Providers are private. Payer is a government-run insurance program that every citizen pays into, has considerable market power to negotiate lower prices. Right? Is that correct? It's the payer is a government-run insurance. The insurance program is run by the government, basically, but private companies also coming in. That every citizen pays into, they pay into this government-run insurance program, considerable market power to negotiate lower prices. So, national insurance collects monthly premiums and pays medical bills. So, government insurance systems, national system, they collect the monthly premiums and pay the medical bills. Plans tend to be cheaper and much simpler administratively than the American style of insurance. So, their plans tend to be cheaper and much simpler than the administratively than the American insurance systems are very high cost. Can control costs by one limiting the medical services they will pay for or making patients wait to be treated. So, this system will have cost control by limiting the medical services they will pay for, or they will have a certain area that what they will be paying, or they can make patients wait to be treated. And then the fourth one is the out-of-pocket model. Fourth model is the out-of-pocket model. Rural regions of Africa, India, China, and South America. Some countries don't have a system as such this thing. So, the people have to pay out of pocket and get the services. The characteristic of this model is only the rich get medical care, because poor people cannot afford, so they don't access those care. Only the rich get medical care, the poor stay sick or die. Most medical care is paid for by the patient out of pocket. Right? There's no insurance or government plan, so it's just paid by the people. So, people who can afford will get the care, cannot afford will not get the care. So, those are the four models. The Bismarck model, which is provided and the payers are both private. Then we have the Beveridge model, provided and financed by the government. It's the opposite of the other one, and that one is provided and provided by the private. Here, Beveridge model, it is provided and financed by the government through tax payments. And the third model, where the providers are private. Right. Payer is through an insurance system run by the government. And then fourth model is completely the people have to pay and get the services. Right. So, those are the four models. Okay. Now, common principles of all these models. When you are talking about a health system, you need to look at four parameters, four areas. So, when you are describing, you should look at these four areas in the that health system that you are talking about. Firstly, the coverage. That health system, how much it covers. Coverage for every resident, old or young, rich or poor, whether it covers everybody. What we call the universal health coverage. Everybody is covered. developed countries except for US. Every country rations care. Not everything is covered. So, but there are limitations, therefore they limit this coverage to various mechanisms. So, one is the coverage, how much of the population, we have to talk about that health system, how much of the population is covered through that health system. Then the second parameter is the principle is the quality. So, people often talk about other developed countries producing better quality results than the US. About they talk about the health system, and so the quality of care, and then the cost. The third principle is the cost. All other systems are cheaper than the US. So here they are comparing the US system with the others. All other systems are cheaper than in the US. Foreign employers pay far less for health coverage than US companies. Right? So you see the effects of those. We can discuss that. And finally, the fourth parameter or the principle is the choice. Many countries offer greater choice than most Americans have. Again, comparing with America, this thing. So, choice of care, whether people have the choice to whether they can access the public or the private health care. So, those are the common principles of all models. When you are discussing a model or describing a model, you must mention about the coverage, the quality, the cost, and the choice. So, these are the four principles that you have to discuss the model. Right. Okay. Then let us look at what do we mean by the word health system. Health system. What is a system first before coming to health system? Where have you seen systems? Any other place before coming to health? What do you mean by a system? Yes, some sort of organized process. Can you give an example from day-to-day life? Even your body, very good. Your human body is a combination of several systems. What are the systems we have in our body? Cardiovascular system. They talk of the cardiovascular system, heart, the blood vessels. Then central nervous system, right? Reproductive system, gastrointestinal system, respiratory system. So like that. So and see the body has harmonized when those systems has to work together. Right? Systems has to work together. Then only you lead this thing. Right? Similarly, in a vehicle or a machine also you have different systems working. The electrical system, the mechanical system, all have to work harmoniously. Then it will work. Right? So talking about those systems and the human body, it comes to my mind a story I used to tell my students. In the human body, the systems were trying to appoint the leader. They were discussing who is the most important of this whole system. Right? And so the brain said, I give signals and I manage everything, all the affairs of the body, right? So I am the big boss here. Then the heart said, no, how can you function? I am the one who pump the blood and I keep all of you alive. So like that, various organs started talking that they are this thing. Then the household started talking. And nobody, what you are doing, you are nobody. Okay, let's see. We stopped work. And few days, 1 day, 2 days, then the brain and everything, they could not function. And then they all agreed. I say, okay, then only we started functioning. So in a system, everybody is important. What I say, I tell this story also to see in the hospital when I go to, considering the teamwork, this thing. And here we have recently seen that breaking down, the nurses fighting with the midwives, the doctors coming on that. So it's a team, everybody is important, even the sanitary laborer is important in an organization working together. So like in a system to be work harmoniously, it has to work together. So system is this thing. So let's look at the health system. How will you define what a health system is? The WHO defines a health system is the sum total of all organizations, sum total of all organizations. We have so many organizations in the health system. There are institutions and resources whose primary purpose, the primary purpose is to improve health. If the primary function is to it, then because we have so many institutions, so many organizations, but some are having now take a hospital or a medical health office or say a pharmacy or laboratory. Their main purpose is helps to produce health. So health system is a sum total of all organizations, all institutions, and all resources whose primary purpose is to improve health. Now take finances, financial system also. Then health financing, which is primary focus is to improve health, it's also part of the system. Hospital system, inpatient care services, it's again another system. Then there is a laboratory system. So there are organizations, there are institutions, or resources like finances, whose primary, and the buzzword is that the primary purpose of that has to be to improve health. Then they become part of the health system. A health system needs staff, funds, information, supplies, transport, communications, and overall guidance and direction. So all this has to be there in the system to function, like different parts of, say, in a watch, in a clock. There are cogwheels. It's like all have to work harmoniously, supporting each other. So in the health system also, these things must to be there. They are brought together to function, to produce health. And it needs to provide services that are responsive and financially fair. Right? Needs to provide services that are responsive and financially fair. Two words, responsive. What do you mean by responsive? The services that these things produce has to be responsive. What do you mean by the word responsive? Any idea? You know the word responsive? Responsiveness is how a health system addresses the needs of the people, Mainly when you talk of responsiveness, talk of the non-medical needs. Right? So a client, a patient coming to a hospital expects certain things. What is the first thing he expects? Expect him to be welcome to the place. Then he expects him to be talked nicely. Right? And offer him a seat and a conducive environment, clean environment. He expects that. And if he is admitted, a clean bed and with all the necessary things, water, the sanitary facilities, how well health institution or a system addresses these needs of the clients, of the patients. That is responsiveness. So then the other factor is the fairness. Everybody to be, because we first learned that health is a basic human right. So everybody must be treated equally. everybody must have equal access to get what they need. So that is what is meant by fairness and financially fair. So everybody should be provided services rather than that there are inequalities in the systems when we look at them, while treating people decently. So these are the two areas. Needs to provide services that are responsive and financially fair. A good health system improves people's life tangibly every day. So a good health system will improve this thing. So when we are looking at health system, we must see whether these things are addressed. The responsiveness of that system, whether they address what the people need, people's expectations, and whether it is fair to everybody. Right. Then what do we expect from the healthcare delivery system? Earlier I mentioned four. Now here they talk of three parameters or goals that they are trying to achieve in a health system. Often they are competing with each other. The accessibility, access to healthcare, quality, and the cost. These are the three broad goals in healthcare delivery. What we are trying to achieve, everybody, because it is to be fair. It should be able to, people should be able to access it. When you talk of access, it does not denote only the physical access, the location where how far the people have to go to get to a health facility. Other financial access also is in there. Maybe they have the right in front of their house hospital, but if charges and they cannot afford to pay, then they can't access that, right? So that financial accessibility is also included in the access, not only the physical access, right? And then the costs. So these are the health system try to achieve these things, keep the cost as minimum as possible, and see that everybody can access these services and then provide good quality care. So we will try to cover some of these countries. So what I want you to consider when you are describing a country is the definition, categories, how we choose to define this country's health system. I gave you the principle, four models of health systems. Look at that health system and put them into what they are. What umbrella terms do we use to describe this country's healthcare system? And then description, what does this country's healthcare system entail? And then benefits and challenges. What are some of the advantages, disadvantages of each of these countries' forms of healthcare? That is what we are, when we are looking at a health system, what we want to learn today. Try to define what category of health system is that, and what are the terms they use in that, and then describe the system, and then look at what are the pluses and minuses of that system. That's what we are going to do today, this morning. Right, okay. So let's look at some of those systems. And who's going to present first? Who's prepared? Do you have a PowerPoint or? Yes, okay, load it in.
Web. I'm Dr. Gunatilaka and this is Laminder. We'll be discussing about the NHS, the healthcare system in UK. When you consider the UK, it includes Scotland, Northern Ireland, Wales and England. And it is the world's largest publicly funded healthcare system. And it's one of the most efficient, the most egalitarian and most comprehensive health systems in the world. It includes the 4 publicly funded systems in the countries I mentioned, the England, Northern Ireland, Scotland and Wales. And it was created in order to create a comprehensive health and rehabilitative services for prevention and cure of diseases. So the 4 systems run independently of each other, and sometimes some functions might be routinely performed on behalf of the other UK departments of health or one for one or more other systems. The individual systems are the National Health Service England, the Health and Social Care in Northern Ireland, in the National Health Service Scotland and the National Health Service Wales. Roughly to show the expense met by each country, in England in 2012 it was 108 billion, in Ireland it was 3.9 billion, in Scotland it was 9.3 billion and in Wales it was 5.3 billion in pounds. It's primarily funded through taxation, but there are some small amounts from the national insurance contribution and other less significant sources of income through overseas visitors and their insurance schemes. Then the charges they make to patients for prescriptions and dental treatment through the hospital car parks and other patient telephone services. They provide a comprehensive range of health services, and vast majority are free at the point of use for people legally resident in the United Kingdom. That's about 63.2 million at the moment. Patients who do not qualify for free treatment are asked to pay in advance or to sign a written undertaking to pay. It covers everything from antenatal screening and routine treatment for long-term conditions to transplants, emergency treatment and end-of-life care. Shamin, they'll talk about specifically the healthcare system in England.
Okay, as we have discussed about the health system in UK, we have for demonstration purpose taken out NHS England to have a little deeper look into. So we can identify this system as out of the 4 healthcare models as beverage healthcare model. And if you consider NHS England model, in the middle round there are clients. Primarily they are being treated by GPs, general practitioners. If they cannot deal with the illness of the patient, they refer them to the hospitals. That's the ideal system. Then the surrounding circles are governing bodies, which includes NHS England, Health Watch and several other organizations. As we said, the providers of primary care are the first point of contact for the patients, including GPs, dentists, opticians and pharmacists likewise. National Health System England was established around about 1946 under the National Healthcare Act. It functioned as the same for long years, and there was huge reconstruction happened around 2013, and some of the governing bodies were dissolved and new governing bodies were established. The planning and purchasing of national health services is undertaken by organizations known as commissioners. We will talk about it. So clinical commissioning groups, there is a system called clinical commissioning groups, or CCGs. They made up of doctors, nurses and other health professionals who will serve the patients. This clinical commissioning group is accountable to the NHS England, that is the main governing body, or we call it as NHS Commissioning Board. Their responsibilities are assessing the reasonable needs of their population, using their buying power as a purchaser to secure services needed by the public in the highest quality, and to meet the NHS standard with care and in the provision of price. So we discussed CCGs are responsible to the NHS, and the NHS is responsible to the Secretary of State for Health for how well they are performing to address the public needs. And there's another organization called Health Watch, recently established. They spotlight on health and social care services, mainly about the public health care services. So the Secretary of the State for Health is responsibility to promote a comprehensive health service in England. He has a ministerial responsibility to the Parliament for the provision of healthcare services, and he is basically responsible to direct the governing bodies to give the strategic direction and to achieve cost effective and quality care to the people. So this is the NHS outcome framework as they have established: preventing people from dying prematurely, enhancing quality of life for people with long-term conditions, helping people to recover from episodes of ill health or following injury, ensuring that people have a positive experience of care, and treating and caring for people in a safe environment. So as we discussed, NHS provides a comprehensive service available to all, rich to poor, young to adult. It is based on the clinical needs, not depending on one's ability to pay. If it is a minor condition, that will be treated by the GP, or he will be go through the health system, along the health system for hospitals. And it put patients first. The NHS works across the organizational boundaries and in partnership with other organizations in the interest of patients, local communities and the wider population. It's providing the best service for what they pay to the public. So these are the guiding values of the NHS: working together for patients, respect and dignity, compassion, commitment to quality care, improving lives, and give care for everyone. So these are the responsible organizations in UK to deliver the health care: NHS England, Public Health England, the NHS Trust Development Authority, and Health Education England. There are some safeguarding bodies for the healthcare professionals, as the the people are very educated about the rules and regulations and the laws and their rights. There are safeguarding bodies for the practitioners: the Medicine and Health Products Regulatory Agency, the Human Tissue Authority, the Human Fertilization and Embryology Authority, NHS Blood and Transplant, the Health Research Authority. And there are also professional regulation bodies also to make sure that each and every practitioner is up to date and qualified. Yeah, if you see this, this will give you a brief idea, and which compares the quality of care, access, efficiency, equity, and healthy living conditions and health expenditure also. You can see the UK is ranking almost all components except timeliness of care, that means efficiency, and yes, healthy living and all those things. There are small problems. Other than that, effective care, so safe care, coordinated care, patient-centered care, they are excellent. So we can identify the advantages of the system. Everyone has the access to exactly the same health care, the equitable health care, and there is a universal patient database. That means wherever you are admitted, the next time you can go another place and everything is in the system. It is made up of a referral system that relieves the burden to the specialist, and appointments made on medical priority. And there are several disadvantages of the systems also. It's tax funded. Each and every person may not be able to bear up the taxes, and there is a concept of quality versus cost. When you are going to improve the quality, the cost is high. If you are cutting down the cost, the quality goes down. And no direct access to a specialist through the NHS, and long waiting list for non-urgent cases, and lack of availability of some treatment because they are considering of the cost. These are our references, and thank you very much. Beverage. Access. Yeah, their role is really now the NHS England is mainly responsible for the inpatient care. So their role is to make sure the customer's experience, whether they have got the right treatment, whether discriminations, and also the community care. They are responsible. Yeah, the same one. Not for community health, NHS is not mainly hold the responsibility. Government. Government. Yes.
like to discuss about little bit about the health system. Now you know what is the health system and definition. The definition I got it from the WHO website. Health system is the sum total of the organization, institute, and resource whose primary purpose is improve health. We know about that. I would like to introduce a little bit about Malaysia. Malaysia is a federation of 13 states and 2 territories in the parliamentary democracy, with the prime minister and head of the government and constitutional monarch elected by the Sultan. The Malaysia is multicultural society and secular state with Sunni Islam as the official religion, classified of the World Bank as an upper middle income country. It is society and economic where the transferred rapid economic growth in the later half 20th century. The objective of the Malaysian health system is the government set out the ambitious goal of the health system in its vision of the health. The Malaysia is to be a nation of the health individuals, families and communities through a health system that is equitability, affordable and efficient, technological, appropriate, environmental and adapted and consumer friendly. This includes the emphasis quality, innovation, health promotion, respect of human dignity and promoting individual responsibility and community participation and enhance of the life quality. The organizations and governance of the health system. The Malaysian healthcare system consists of tax-funded and general tax-funded and government-run universal services, and they are very fast-growing private health sector. Public health sector services are organized under the civil service structure and are centrally administered by the Ministry of Health. The Ministry of Health and Plans regulate most public sector services, but so far private sector regulatory. Legislation governing healthcare professionals requires them to register with state professional bodies. The Ministry of Health also regulates the pharmaceutical industry and food safety bodies. The healthcare financing. The Malaysian healthcare finance mainly through the general revenue and taxation collected by the general government, while the private sector is funded through the private health insurance and out-of-pocket payment from the consumer. The spending of health at 4.5% GPD in the 2010 remains below the average of upper middle income countries. The spending on the health expenditure has remained the predominant public spending at the 55% of total health expenditure. The main source of the PHE in 2009 were the Ministry of Health. It is 46% of total fund. Household of out-of-pocket expenditure 34%. This pattern for spending are finance option include the establishment, social insurance schemes, and the physical and human resources. The number of primary health care clinic and dental clinic has increased in both public and private sector, as they have number of hospital beds, although through population ratio and bed has declined slightly since 1980. The supply of health professionals, however, remained the serious below of the remaining number of the, although government had increased number of training places. provisions of services, the national health policies stress public health and health promotion. The Ministry of Health has developed an extensive network for public primary care centers and also dental services, especially for children. But these services are under the restraint and have staff shortage. So patients often encounter long waiting lists. Primary care centers only limited can prescribe functions since people can bypass the referral from the general practitioner, and for small additional fee can go directly specialist or hospital. Government service increases serve the poor and private services better than of people who will live in the urban area. The hospital policy currently has three main threats: the strengthening specialty care in large public care in the large public hospital, increasing number of day surgery centers, and expanding top-end private hospitals. Care and center the medical tourism market in Malaysia has large pharmaceutical companies. That sector, the country also supply 30% of the domestic demand. There are some in the Malaysia has there are some positive aspect and negative aspect their system. They are not mentioning what is the model their health system. According to my knowledge, I think health system in beverage model and out of pocket. I think basically both. These are my things. These are my references.
Yes, 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 yes.
So I was thinking, oh, I've read this before.
Right. So I mixed what you have put mixing and then strengthened that with some of the concepts. I will take what you have done for your USA. Nobody has come prepared with that. UK one was presented, so I will summarize that. France, also Australia. So another one you will be presenting. Germany, Japan. So when they come back, you
Yeah, I have a pocket here. That's it. And my dress, yeah. So, hi everyone. My name is Neeta Sivadasan, and I'm from Canada, as Dr. Samarage said before. I just finished my bachelor's degree at the University of Guelph in biomedical sciences, so that's a 4-year degree. And then now I'm starting a master's in public health at Queen's University. And then hopefully that I have a couple more degrees I want to finish still. So it's going to be a little bit of a long journey for me. But before I start, am I talking too fast? I have an accent, so I know that that sometimes can be difficult to understand. I can talk slower too. So far, so good? Okay, then I'll carry on. So I come from this beautiful country called Canada. It was established July 1st in 1867. We have 33 million people, which is a very vast comparison to here in Southeast Asia, where you have a very large population of people for a small square meter coverage, whereas we have a very small population for a large mass of land. So we have the second largest land area in the world next to Russia. There are 10 provinces and 3 territories. We have 2 official languages. We're a bilingual country, so il y a 2 langues officielles. C'est anglais et français. So most kids can speak both French and English, as can I. And we are a democratic government, so we go through a democratic system of passing through policies, laws, and regulation. And finally, the most important thing about the health systems is we're a publicly funded, socialized healthcare system. Now, to understand the Canadian healthcare system, it's important to understand our history. And that was one of the things that Dr. Samarage mentioned about understanding how health systems come to be. So as I mentioned before, in 1867, we passed the Constitution Act, making us a country from the former Commonwealth that was ruled by the British government. Now, between 1867 to 1947, there's a bit of a gap in the time frame. And during that time, the healthcare is mostly private, meaning that most of the people are going to be paying out of their pockets for health care. Now, in 1947, we begin to see some reform in what's going to become our present-day healthcare system, and that started in the province of Saskatchewan, which is one of our 10 provinces, as I mentioned previously. They introduced the universal hospital care. Now, it took some time for a few of the other provinces to carry on that tradition, and they also instituted that same universal hospital care in 2 other provinces of British Columbia and Alberta. But it wasn't until the landmark year of 1962 by a gentleman named Tommy Douglas. If you come to Canada and you say Tommy Douglas, most people will know who he is because we say he's the founding father of healthcare. It was his vision of Canada and the healthcare system that made our healthcare what it is today. And he instituted in the province of Saskatchewan, where he was obtaining leadership there, to introduce a universal provincial medical insurance plan to provide residents with doctor services and additional health care. So here we start to see in the beginning years, as I mentioned before, kind of the vision of the universal healthcare system we now have. But it wasn't until 1966 and onwards that we began to put the policy and the implementations in place to really govern what our healthcare system looks like. So in 1966, we passed something called the Medical Care Act. So this act was passed so that the federal government would agree to cost share some of the costs provided by doctor services outside of a hospital setting. Now, when we moved to 1977, it was a full 11 years until we passed some new policy and regulation in the form of the Federal Provincial Fiscal Arrangements, Established Programs and Financing Act, which shifted the cost sharing that was occurring from 1966 onwards to block funding and tax points. Now, is everyone familiar with block funding? So? Okay. So block funding is essentially the movement of money and monetary funds from one level of government to another. So I'll later talk about how the Canadian government is divided into two different levels. So when we refer to block funding, we're referring from money coming from the federal level of government, or the national, as you would call it here, to the provincial level or the territorial level of government. Now, the other unique part of this new shift from cost sharing to block funding is the tax points. So what was happening was the federal government would reduce the tax that they were asking for the provinces and territories, and the provinces and territories would then thereby increase their taxes so that more of the money that was being collected would stay at that level of government versus the federal. So the federal government just shifted those tax points so that one level would be a little bit more beneficial than the other. Now, the big milestone year was 1984, and this is the year to remember. This is when we passed the Canada Health Act, and it is this act to this day that we govern all of our healthcare system by. So I'll talk about later how the federal government will institute the rules and the regulations, but all of those are based on the Canada Health Act, and we don't operate outside of this act at all. This is like our Bible, if you will. We always go to this to refer to all of our policies and our implementation. Now, like any healthcare system, we've had our flaws and our obstacles and our stumbling blocks. And one of the big things that was a big issue was transparency in our government. Where is this money going? Yes, you're collecting tax from the people, but where are these funds being allocated? And what was happening was there was a former section of the financing district called the Canada Health and Social Transfer. So all the money was being pooled into the Canada Health and Social Transfer, and then from that pool of money, they were allocating it to healthcare, to different services such as education. And what was happening was, because all the money was pooled in this one large pot, if you will, no one was able to really be accountable for where that money was going. So what they did in 2004, they changed the Canada Health Social Transfer, and they divided that into the Canada Health Transfer and the Social Transfer separate, so that the citizens of Canada as well as the politicians could get that transparency and get that understanding of exactly where all the money was going. Now, like I previously mentioned, it's important in understanding the health system to understand how our government is run. So we have two levels of government that really take the majority of the control. We also have a third level of government known as municipal, so that's the local governments, but they don't really have much of a stake as the federal and the provincial government has in healthcare and health systems. So here we have the federal government. Now, the federal government is what provides the structure for our healthcare system. They're the ones that give the rules and the regulations and the orders in which the provinces and territories have to govern their healthcare. And they make these rules and the regulations and the decisions that they make through the Canada Health Act. And we'll go through the Canada Health Act so you can understand what exactly that entails. The other big role of the federal government is the financial decision making. Now, they don't necessarily decide how the money is spent, but they decide how much each province and territory will get. So a lot of those decisions are based on a variety of factors. One of them can be the size of the province, how many people are in the province, how many people will be dependent on the health care. If we look at the aging population, if we look about new children being born. So there's many different factors that are going to take into play for the federal government to make that decision of how much money each province gets. So when I showed you the map before in the previous slide, you can see that some provinces are very large and others are really small. If we look at in comparison to PEI, PEI is smaller than Sri Lanka. So that is one of our provinces. But then we have Ontario, which could probably engulf Sri Lanka multiple times over and over again. So in understanding the disparities between the size and the landmass of the population, we then have to make our healthcare be a reflection of that. Now, if we move down under the federal government, we then have the provincial level of government, or provincial or territorial. Because we have three territories in the north, they're pretty much equal and the same, so we say provincial or territorial government just to be respectful of their territory. Now, at the provincial level of government, this is where the primary health care is going to be managed. And what I mean by that is this is really the level of government where the action of the healthcare is going to take place. So they're going to be deciding what healthcare provisions they're going to provide, how they're going to provide that, how certain services are going to be charged and billed, how are they going to organize their triage system or their waiting system. So all the healthcare system main decision making, the action that's going to be occurring in the health system is at the provincial level of government. Now, because of the provincial level of government's very dominant and substantial role, what ends up happening is we have a very decentralized healthcare system. So although we have the top level, the federal government kind of controlling and looking over what's going on, the real people that are doing the grunt work of the healthcare system are the provincial. And it's not just the provincial government that plays a stakeholder. We have doctors who become their own independent contractors, meaning that they're not government doctors. They run their own clinics and their own businesses, and they bill the government for the fees and services that they carry out. And we also have the existence of multiple organizations outside of the government that will be providing services. So if you're wondering what that looks like, that could be diagnostic imaging, ultrasound departments, different laboratory services that provide blood work, or any type of other testing that the hospital can provide, but they provide separately for their own benefit as well. So because of that, we have a bit of a disparity in how our government is controlled, and with that I'll discuss how that brings about some challenges in making decisions. So this, like I mentioned before, the Canada Health Act is the golden Bible, if you will, that we situate our healthcare system on. So we have 5 main principles as stated by the Government of Canada which guideline the Canada Health Act. So the first one is public administration. So provincial and territorial plans must be administered on a non-for-profit basis by public authority accountable to the provincial or territory government. So the big take-home message of the public administration, it must be done by the people, and also there can't be any profit that's being gained through the healthcare system, so not for profit. The second main point is comprehensiveness. The provincial and territorial plans must ensure all medically necessary services provided by hospitals, medical practitioners, and dentists working within a hospital setting. We also have the key aspect of universality. Provincial and territorial plans must entitle all insured persons to health insurance coverage on uniform terms and conditions, meaning that if you have health care and your family member in British Columbia also has health care, that health care that you both receive should be as equal and universal as possible between the two. It shouldn't be that the people in British Columbia have more superior health care than you. So that's another big thing to keep things equal across the country. The last 2 pillars are accessibility, meaning that provincial and territorial plans must provide all insured persons reasonable access to medically necessary hospital and physician services without financial or other barriers. So this is what we discussed before in some of the other presentations as well. So at the point of service, there is no charge. So this gives people that both have financial means and both people that don't have financial means to get the best health care that they can get in the country. And the very last pillar the Canada Health Act is built on is portability. So provincial and territorial plans must cover all insured persons when they move to another province or territory within Canada and when they travel abroad. The provinces and territories have some limits on coverage for services provided outside of Canada and may require prior approval for non-emergency services delivered outside their jurisdiction. So this is really important when Canadians travel, or maybe if they live abroad or do an internship like me overseas. But it's also important when we move from provinces and territories. So even though I live in the province of Ontario, if I chose to move to Quebec, which is our neighboring French-speaking province, I still am entitled to an equal amount of healthcare as I get in Ontario. And just because I change provinces, that does not mean that my healthcare is limited. Now, if we look about how we receive healthcare, that fifth point really comes into play. So when you want to receive healthcare in Canada, say you come to Canada, you've now established your citizenship and you need to get your healthcare going. So what you want to do is you want to apply for coverage based on the province or territory which you are living in. So I live in the province of Ontario. So if I were to go back and reestablish myself, I will then make an application to the government of Ontario asking for healthcare coverage. Now, during that time of the application, I will then receive a health card. And I have my health card if you guys are curious to see what that looks like in my bag, so just let me know afterwards. And that health card is like my identification number. So I'm associated with a number that is associated within the healthcare system that attributes my past, present, future medical records. So all they have to do when I go to the hospital or when I go to a doctor is they look up my OHIP number or my health card number, and all my previous medical history shows that. All the previous visits, why I went where, all these things come. So we have, although we have this kind of digitalized system, there are some people that still use the OHIP card number in a more paper-based setting as well. One of the main points under waiting for your health card is that it can't exceed 3 months. So if you apply for healthcare coverage and you don't get that within 3 months, that becomes illegal in Canada. Because under the Canada Health Act, everyone should receive healthcare coverage as soon and as fast as possible. They've given 3 months as kind of that waive period. And so I talked about the healthcare number. Now this is what the look of our healthcare system generally looks like. Now very similar to the UK presentation that happened, we have a primary healthcare provider in the terms of a general physician. And now in the blue over here, this general physician acts as our gatekeeper. So we are unable to bypass the system to go see a specialist or another secondary care provider. We all have to go through this general physician, and this general physician decides where we go afterwards. So if I come in with some sort of a sickness, I will go to my general physician or my family doctor, and he will then decide where I go from there. If he thinks that it's something that he can treat and handle within his jurisdiction, he will do so. If he thinks that it's something that I need more tests or I need more assessment for, he will then send me to the secondary healthcare providers. So I've divided that into 3 kind of subheadings so you can see how that's divided as well. So the first one could be your hospital. So if you need more immediate and intensive care, they will send you to the hospital. But the hospital isn't always the first round of care that you go to. You can go to the hospital in an emergency setting. We have an emergency room. And then at that point too, you still see a general physician that makes the same decisions as a separate clinic as well. So even though you can go through this route immediately as well, it goes through the same hierarchy as shown in the chart. Now, is everyone familiar with the triage system? Yeah, okay. So we all know that the triage system was established during the war times in dealing with wounded soldiers. And so the triage system is based on, we see people based on the severity of their case and their ailment. So the first thing that happens when you come into the hospital, I work in the emergency room, so I know this land very well. We will come and we'll greet you and we'll say, okay, have a seat until you see the triage nurse. The triage nurse will then come and make the first initial clinical assessment. So they will take your health card number, your blood pressure, they'll listen to your heart and assess what the situation is. And then based on that, they will rank you on where you need to go after that to see a general physician, to see a specialized physician. And then that order is what is set in the emergency room to see the most severe to the least severe. Now, the other route that you can be sent through in the secondary healthcare provider is a specialized physician. So these are the people that are not general physicians but have a more specialized area of expertise. So we're thinking about nephrologists, urologists, cardiovascular surgeons, the people that really have an intensive knowledge of one particular area. And finally, we have external organizations. So I mentioned before how our healthcare is decentralized. And one of the components of decentralization is the external organization. And part of that can include diagnostic imaging. So for example, even though our hospitals can provide diagnostic imaging, there are separate companies that exist where you can still go and get your diagnostic imaging done, and some people prefer that because it's faster. But it's important to note that they are not private. In Canada, you cannot exist a private clinic, a private organization at all under the Canada Health Act. Everything must be universal. So even though I can go and get the imaging done because it's faster for me and maybe they have more facilities, they still bill the government. So any person that sees you in your healthcare, sees you in treating it in the healthcare will send a set of documentations to the government with your health card number saying, Netha Sivadasan came in, her health card number is XXX, and she came in for pink eye, and the pink eye code for the provincial government is 321. And then the Ontario government will recognize that code as 321 and then pay the necessary fees for that ailment for that time. So like any healthcare system, we need to understand where the money is coming from. So the healthcare in Canada is publicly funded through taxation of personal and corporate income. Now I know on the sheet that we went through, it said that Canada was a national health insurance coverage. But I would beg to differ that it's probably a combination of the national health insurance as well as the beverage model, because you have the taxation aspect there. And in a lot of the reading and the literature that I've been looking at, it seems as if there's a big discrepancy and a lot of argument between what we would classify our system, because we kind of take bits and pieces of many systems and incorporate it into what we have. So I would say probably the best identification is the beverage or the national health insurance model. So after taxing occurs, we then get that big pool of money that goes to the national health transfer that I talked about before. Then from the national health transfer, the federal government looks at this pool of money and then decides how that's going to be distributed to provincial and territorial level of healthcare. And then at that level, the province and territory, they're the action makers. They decide how much money is spent. Now, as I mentioned before, every healthcare expense billed is billed by the physicians and paid by the government. So every ailment you can think of under the sun, there's a code for. And that code is determined by the government so that when the physicians bill based on that code, then the government can pay that allocated fund. So like most universal healthcare systems, we can all think of the benefits which occur. It's free, it's accessible, you get good coverage, it's pretty low cost in comparison to some of the other countries like the United States. But we definitely have some challenges. One of them being the tension that I talked about between that federal and provincial level of government. So sometimes there can be a lot of discrepancies between what the federal government decides and what the provincial and territorial governments think they deserve and need. So some provinces will say, you know, oh, the federal government, why are you giving me $30 million worth of budget when our province has so many immigration rates? We have a very large population. We need more money. But then that's not in their control to ask for more money or ask for less money. So that can create a lot of disparity and a lot of tension, because you have the people that are doing all the grunt work, but then you also have the federal government who are making decisions that determine how that work is done. So sometimes that can create a lot of obstacles between those two levels. We also see the emergence of the private healthcare sector. Now, as I mentioned before, it is illegal to have private clinics within Canada. However, what's happening is, because we have a very close neighbor below us, the United States of America, many Canadians, when they don't want to follow through with the wait times to get services, different health services, they will actually travel to the United States and pay for their health care there. So that's a new trend that's being seen. So especially for things that will take a very long time, like seeing a specialized physician, or if there's a certain surgery that you're waitlisted for a year for, many people who have the funds will travel to the States, pay the fee, and get the healthcare done there. So that's another kind of challenge we're starting to face of Should we be going private? Should we incorporate more private clinics? So that's an ongoing debate. And the big thing, because we have a universal healthcare system, is we have a shortage of doctors and nurses, and as a result, we have very long wait times. So when I work in the emergency room at the Gulf General Hospital, I always tell patients, if you can get in and out of here and see a doctor with your prescription in an hour, you should consider yourself lucky. Because to even see the doctor on most days will take you at least 2 or 3 hours itself. Then to see the doctor, and if he sends you somewhere else for test work, that can take another 3 or 4 hours. So you may have something as a simple cold, but it could take almost up to 8 to 9 hours for you to get to see someone, to speak with someone, and get the proper medication and diagnosis to get out of the door. So that's one of the drawbacks of our healthcare system. However, we've started to improve this by focusing more on something we call telehealth. So what patients can do in Citizens of Canada, they can call into a telehealth number, which is a registered nurse on the other end, explain with the symptoms of what's going on, and then the nurse can then advise them right then and then on the phone whether they need to go see a hospital, whether they need to see another doctor, or whether what they have is something that will pass on its own. So in that way, they're starting to filter down the numbers so that they can manage the wait times. And another big shift is they're starting to train more specialized nurses, meaning that, yeah, you have your regular nurses, but they're starting to increase the capacity of, I don't know what the term is here, but it's a nurse practitioner. That would be the thing. So then this level of nursing, you're able to write prescriptions. You have a bigger flexibility to do a lot more, very similar to what a physician can do. And because they're training more nurse practitioners, they're trying to get more people seen as quickly as possible for things that don't need a doctor. So that's another way they're trying to decrease the wait times. And finally, the biggest issue we have as any country is the growing healthcare costs. Healthcare costs a lot in any country you go to. It was reported in 2012 that $207 billion, this is Canadian dollars, was spent on healthcare alone in that 1 year. And even that number is considered to rise because we have the emergence of the aging population, the baby boomers. So we are now at a crossroads of trying to decide, yes, we love our healthcare system, and it's something Canadians we take pride in, especially when we talk to Americans. We love to brag that we have a universal healthcare system and they don't, and that they're missing out on a very good thing. That's something, if you ask any Canadian, they will very, gladly brag about our healthcare system. But the fact of the matter is this sustainable? Can we keep the healthcare system we have and keep the quality of care that we have, which is very good, even though you wait for it, when the healthcare costs are going so high? So now we have to start looking back at our system and seeing how we can, still have an efficient healthcare system and also save costs as well. So that's the end of my presentation, just use sources. And if you have any questions, I'd be happy to answer them. Yeah. Okay. Yeah, okay. Mhm. Mhm. Okay, okay, two good questions. So the first one I'll address. The Canada Health Act is still in place, and it hasn't necessarily been changed or altered. And if you go, especially understand the way Canadian government works, it's very difficult to implement an act. It's also even more difficult to rip up an act and say, no, we need to do something else. So a lot of times what happens is they keep the Health Act as kind of the guiding light of the healthcare system, but they'll institute maybe different policies or different acts to supplement or complement that act. So one of the big ones was that Canada Health Transfer, because it first was the Canada Health and Social Transfer, and then they did some retweaking and wrote a new policy and then changed that to the Canada Health Transfer. So that's how they kind of manage and navigate the sticky situation of having a very aging document to guide things by. And then for your second question, it depends on the patient case. So if you go to your general practitioner and say you have a heart problem, and they send you to a cardiologist at the hospital to be treated, and that cardiologist treats you and says, okay, if you take this medication, then I think you'll be fine. So at that level, if you have received the health care that you need from the cardiologist and the cardiologist feels that you don't need to see him anymore, he will refer you back to your general practitioner and say, you know what, I've managed the situation as it is. You can go back to your GP if you have any other problems. The other situation is if he's given you treatment and he still wants to check up to make sure that you're okay, you're following the protocol, that your body's responding in the way it should, he will then continue to give you appointments and referrals for follow-up appointments. So you will always have a general practitioner to kind of respond to, but sometimes what will happen, if it's a case that needs prolonged treatment or prolonged attention, that specialized physician will still keep you under his care and wings until he feels like you don't need to see him anymore. Yeah. 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 Okay, so we have we have Healthcare Canada. So Healthcare Canada is a branch of the different ministries we have in the government at the federal level. Under Healthcare Canada, we also have subdivisions as well, very much so like the government of Sri Lanka, that will handle outbreak concerns. So in that situation, that group of people will handle an outbreak, and they will advise people not only at the provincial and territorial level, but also on the local level, how the local public health practitioners are going to handle this, how the public health nurses need to be aware of things, anyone that will be in contact with keeping the general public healthy, they will then be advised. So we do have a group of people that lead that mission, if you will, but that group of people's responsibility is to contact every single level of our healthcare system, starting from federal, provincial, and downwards up until municipal and local, to advise people accordingly to handle a situation such as that. So a good example that I can think of was H1N1. So when H1N1 came, probably about 3 years ago now, they were on the verge of saying it was an epidemic because so many people were getting it and they weren't quite sure at that point where it was coming from. And so what happens is Health Canada is the first one to take the charge, and that same outbreak division, of how to advise the situation based on their expertise. The next level happens is the provincial and territorial government. So they take that information and they say, okay, with our healthcare system, what do we need to do to make sure that the people of our province or territory are kept safe? Then the next level after that, so in the case of the H1N1, they had developed a vaccine at that point. So there was a big push for getting everyone vaccinated. So Health Canada had said, okay, we approve this vaccine and we think it's effective. The provincial level of government says, okay, we think this is a good idea. Now, how do we implement that so that everyone will get vaccinated? So then they now talk to the local public health people and the practitioners and the doctors and the nurses, and they then start advising them. And what the outcome of that was local pop-up clinics that were emerging in schools, hospitals, any public area to get people vaccinated as fast as possible. So it all trickles down, but there's a level in which people dictate that. Yeah. Any other questions? Yeah.
But the central government also kept with it running. They are running the
Yeah.
What is there? Like the federal government is also doing all everything. Services are run by the provincial.
Yeah, everything is run by the provincial setup. We don't have a national hospital or a national teaching hospital. We do have teaching hospitals, but then that goes through a bit of another situation because the teaching hospitals are routed through the secondary institutions. And then they're also separate from the healthcare sector. So they will run the teaching hospitals and train the doctors and nurses and do all that, but that's not under the federal government's control for the most part. That's mostly the secondary institutions' control. So that's where one of the big kind of differences as I've been learning the Sri Lankan healthcare system. So, yeah. Any other questions?
How is the financial flow from the federal government to the provincial government? Are they generating more? Or does the federal government also give some funding?
So the provincial government only gets money from the federal government, and the federal government allocates that money from the taxes, from taxes. So that's how they get it. The provincial government doesn't take money from anywhere. They have to get it as part of the budgeting and allocation through the Canada Health Transfer. Yeah. Home-based care. Yeah, so we have palliative care. So palliative care and home-based care are very similar. Most people think palliative care and they think of the aging population of people who are old, but palliative care has extended now for cancer patients, people who are chronically ill, people who are on life support and they know that their time is going to be near. So we do have palliative care centers that actually there's one very close to where I live that honestly it doesn't even feel like it's a hospital, just feels like a home and it just so happens people are there. And they try to make it as comfortable as possible for people's last wishes and last moments of their life. There also is opportunities for home-based care as well, but it gets a little difficult because there's only so much you can do at home, right? And like for example, she would be my great aunt. She's bedridden and she had a severe diabetes, so her leg was amputated. And she refused to go to a nursing home and she didn't want to stay in a hospital either. So she's receiving palliative home-based care. So a nurse will come in twice a day and will look after her, check her, make sure everything's okay. We'll change her beds, change her dressings, give her a sponge bath. So they do have opportunities like that. And in cases like that, I believe it's not fully paid for. I think it's partially funded, if not most of it. But I think there is some level where it does come out of the pocket too. So in like most universal healthcare systems, there's always some exceptions and some gaps. So another great example is dental care. Dental care is covered. But say if you want to get braces because you have a severe underbite and they want to put braces to straighten that, that is not fully covered. So you have to pay that. And to get braces, my mother just got her braces taken off. I think it was upwards of $10,000. So then that you have to also figure out. But then even in that, there's other kind of loopholes as well. So say, for example, my father works for the University of Guelph as a professor. He will get additional health care as part of his job. This is separate from the universal health care that can be provided. So even though, say if I need braces or if I need a root canal, which may not be provided for the universal health care, through his health care, because I'm his child, I can receive the benefit of it being covered. So even though there's universal health care, there's little loopholes that can either stop your coverage, but also can cover your coverage that isn't being covered. So it's a little complicated, but it works kind of both. It's very similar to NHP. Like there's some things that are covered and not covered, and then there's loopholes if you have certain specialized insurance to cover certain things. So it's like that, I think, in most places, the combination. So any other questions? Okay, thank you.